Welcome to today's webinar, Made for This Moment, Nurses on the Frontline. I am delighted to be here, and I want to just give a special shout out to all the nurses that are out there. I've been talking to more and more nurses over the past couple of weeks, and I can tell you, we owe you a debt of gratitude. I am truly grateful for all the work that you are doing. I want to remind everybody that's on the call to use the chat box to introduce yourself and the organization from which you are coming. And at the end of this presentation, we're going to save some time for you to be able to put your questions. And there is a Q&A box at the bottom of your screen. And I would invite you, if you've got any technical issues, to use the chat box. But if you have a question, please use the Q&A box and you'll be able to communicate with us, and we'll take those questions at the end of today. I want to do a big shout out and a big thank you to our sponsor, VanCare. VanCare is sponsoring all of our events and activities for Nurses Week. And Janet, if you take us to that logo. VanCare would like to wish all nurses Happy Year of the Nurse. We thank you for what you have done, what you are doing, and what you will do in the future. You are heroes to everyone you touch. And the next time you go to move or transfer a patient or resident, think safety. And then think of VanCare and how our US manufactured lifts are here to serve you as you help others. VanCare, we are grateful for your sponsorship for the nurse activities, not just today, but throughout the week. And we'll describe what some of those are later on in our presentation today. So today's session, Made for This Moment, Nurses on the Frontline. And for those of you who may not know, the World Health Organization designated, I think prophetically, that 2020 should be the year of the nurse. And it was in honor of Florence Nightingale, one of my personal heroes, 200th birthday. The Week of the Nurse, May 6 to 12, is designed every year to kind of, it really is landing on Florence Nightingale's birthday, which is the 12th. This would be her 200th birthday. And nurses are honored every year annually during this week. So especially this week, and especially because of the COVID situation, we really want to make sure that nurses truly are honored for all of the heroic efforts that they are engaged in on the front lines, and especially during this time. The other thing that I wanted to let folks know that today's session has been approved for one contact hour for nurses through the Maryland Nurses Association. There have been no conflicts of interest identified. In order to receive the contact hour, you must be present and attentive for the entire program. And you will need to complete a contact hour evaluation form, which is located in the handout section of this webinar. And at the end of the presentation, we will provide email address for where you can send some information, your evaluation. So let me introduce you to today's speakers. And these speakers are personal favorites of mine. They're friends of mine, and they're people that I feel have such relevant information to share at such a time as this. And I'm going to introduce Dr. Barbara Bowers, who is a nurse. She has been a teacher and a researcher in long-term care for over 30 years. Most of her work focuses on workforce development and organizational design as they relate to both care and work-life quality. She was one of the researchers on the National Greenhouse Evaluation and was also an evaluator on the Wellspring and Person First programs. She now serves on the faculty of the University of Wisconsin, Madison School of Nursing. So as a nurse myself, I so appreciate the value of good research and data that will help to inform better care and practices. And it was in this context that I met Barb years ago. And I can tell you, I hold Barb and her work in the highest regard. Her research on the greenhouse model has really helped us to learn from and then refine our education, our tools, and our resources to learn and then better support the nurses and the care teams that are a part of the greenhouse model and its implementation across the country. Thank you, Barb, for being here today, and thank you for your incredible work. Dr. Jonathan Evans is a geriatrician in Charlottesville, Virginia, who focuses on the care of people in nursing homes and other residential care settings, as well as the care and support of people living with dementia and their caregivers. He has a background in public health and epidemiology. In addition to caring for individual patients, he is a consultant for several national healthcare organizations. He serves on the board of organizations committed to advocating for consumers of healthcare, promoting person-centered care, changing the culture of aging, and improving healthcare quality. For the past few months, most of his time has been spent on protecting residents of senior housing and long-term care settings from COVID-19 and supporting the long-term care workforce. So I met Dr. Evans years ago when he was the president of AMDA, the American Medical Directors Association, and we were both part of a think tank that was really designed to look at ways we could better support people living with dementia. Dr. Evans more recently, as kind of referenced in his bio, he found himself on the front lines where COVID first hit a nursing home and received a lot of attention, and that was in Kirkland, Washington. And he's going to share just a little bit of his observations on what he saw there. And more of that, not just today, but he will be back to share more of those insights tomorrow. So before we get into a conversation with Dr. Evans, I'd like to just share a video tribute to all the nurses out there.
Thank you, Florence, for being a lifelong inspiration, for answering the call, setting the standards of care, for being a reformer. Things have changed a bit in the 200 years since your birth. We have technology you couldn't imagine, virtual simulations, AI and robotics. But all this science and technology are nothing without care. Something you taught us, something we never forget. As we make our nightly rounds, as you once did with your gaslight lamp and heart of gold. We are in the field, in the OR, on the front line of care, and every one of us stands tested, stands ready. You changed nursing forever, Florence, with evidence at the ready, the role model for clinical judgment, and we continue in your tradition to navigate the sea of change, pursuing our calling, balancing the art and science of nursing. We are Walter's Kluwer, and for this year, the Year of the Nurse, we wish you, Florence Nightingale, a very, very happy 200th birthday.
Well, thank you once again to all the nurses out there. So, Dr. Evans, thank you for being here. Thank you for taking time out of your really busy schedule. And I know today even you had calls back to back, so I appreciate you taking some time. So I want to get into your experiences in Kirkland, Washington. But before we go there, I just thought I'd give you a minute to offer your personal tribute, acknowledgement to nurses. We can't hear you. Try.
Let's see here.
There we go.
Can you hear me now?
Yes.
Thanks. Usually I start talking before I start thinking, so I was just warming up there. No, I just can't thank you for enough for having me, and I want to thank so many of my nurse colleagues that are on the phone right now on the call, and it just means so much to me, especially on this week of all weeks. And to all of you on the call, I just want to take a moment to extend a personal thank you to every one of you, not just for the vital work that you do, which is hopefully getting more attention than it has, but also, just as importantly, for being the person that you are and for living your values. And it's these values that will sustain each of us individually and all of us together, and really all of humanity as we deal with this new reality. And it may seem a little hyperbolic, but I believe this in my heart of hearts. Thank you for rescuing the world. The word nursing comes from a French word that means to nourish. And, you know, you are nourishing the spirit of our society and the world right now. And no one else could do it but you. And I just want to say, I really believe that we don't choose our work, that it chooses us. And, you know, it's part of who we are, and it's what God made us to be. And I was just thinking before the call that, you know, when I heard about how many people are on this call, it occurred to me that, you know, each one of you, we're physically separated all around the country. And in addition to that, in addition to being scattered all over the place, each of you has had your own personal journey throughout life. And, you know, and yet everything that has happened to each of us throughout our entire lives, all on our own different journey, has led us to this place and this moment. And so I don't think that's in any way accidental. I think that's entirely purposeful. And so because of that, I just want to say to each one of you that this is the place. Your heart has taken you here. So thank you and welcome home. And especially selfishly, thank you for helping me feel that I belong. It means everything to me. And I've spent much of my career searching for a place where my values were shared, supported, and encouraged by the workplace. And I found that in order to find that, I had to be in a place where doctors were generally absent, but where nurses were always present. And so I work in places that are called nursing homes, and they're not doctors' homes, and I like it that way. So anyway, thank you for indulging me on that. There's more I'd like to say about Florence Nightingale and each of you, but I'll get to that a little bit later.
Wow. Well, thank you for that. And those were inspiring words, and you can understand now for those of you on the call why we asked Dr. Evans to be a part of this really important way to kick off Nurses Week. So let's go a little more deeply into your experiences at Kirkland. Tell us a little bit about what called you to Kirkland, kind of what you did there, and some of those observations.
Sure. So there's a nursing home in Kirkland, Washington, which was really the first major outbreak in the United States, and it's operated by a company that I've had a relationship with for about a decade. They have hired and they've hired their own doctors and nurse practitioners in a number of facilities, and for the last decade I've trained them. And when this outbreak occurred, they called me immediately and asked for my thoughts, and so I've been in close contact with them. And over the next days and even a week or two, as I heard more, I watched TV and I heard more and more about what was happening, and I felt sort of helpless, and I felt like I needed to do something, and so I volunteered to go out there on site and talk with the public health folks that were there, and most importantly to me, to talk with families that had loved ones there. And just remember, even though it was practically just 2 months ago, it seems like an eternity, but because this was the first place, we didn't have these stay-at-home orders. Visitors weren't banned from nursing homes. Protective equipment wasn't widely available. And so this was all new, and this was the first place where family members were not allowed to visit their loved ones, and testing, generally speaking, was not available, and people weren't exactly sure why. And there was even a story that really broke my heart where in an effort, so many people got sick that worked there and that lived there. The medical director himself got sick. He had pretty much all the patients. His nurse practitioner, of course, was there in the trenches pretty much every day, but he was having to deal with things over the phone. And I even remember a story that I saw on CNN or something where, people were trying to communicate through a closed window in a wheelchair. And there was one woman who reported that someone called her to say her mom was doing fine, and she had to tell them that several hours earlier she was called to say that her mother had passed away. So I just thought that if I could do anything, I could talk to some of those families.
Wow.
And I'll just tell you, when I got there, so I went there on purpose. I volunteered to go there, but and I knew that when I came home, I would need to quarantine myself. But I'm a little bit embarrassed to confess this, but I was afraid. I mean, the doctor that was there was out sick. This is a new disease. Nobody knew exactly what was going to happen. Many staff had gotten sick, and I was afraid, but I felt like I needed to be there. And I just thought that if the nurses were there and they were doing what they were doing, that it would be an insult and an offense to them for me to stand out in the parking lot or something. So I went in there and I met all these brave nurses many of whom had volunteered from other facilities and other communities. And they were brave, and they made me feel brave. And they weren't afraid, not only were not afraid, they were cheerful, and they were full of life, and they were celebrating the people that lived there and celebrating each other. And they just felt this tremendous sense of purpose. And it just was one of the most inspiring things that I'd experienced. And I just felt like I'm part of something bigger than myself. So I was very, very grateful for that. And in addition to that, when I talked to family members, I met several in person. I talked to others over the phone. I was just struck by their grace, how much concern they had for not only their loved ones, but for their loved ones, family inside, the other residents, the staff, and their genuine concern for everybody. And also just this tremendous desire to help and do something. And I felt that one of the things that made me the saddest, aside from what I saw with individual patients, was that, these family members who, part of their life's work was to care for their loved one or to be with them. And suddenly they were not allowed to do that. And they were trying to find ways where they could, carry out their life's work and their life's mission by being connected, even though they physically couldn't be together, making homemade meals and dropping them off. There was one woman I met who was just awesome. She was a nurse herself. She actually was taught infection control at a hospital. And as we were sitting outside, because she couldn't go in and we were talking, of course, back then the recommendation was for 3 feet of social distancing, and now it's 6 feet. So, but because things keep changing, we keep learning. But she was outside and she was watching people entering or exiting and trying to identify where they're using the PPE properly. And she just wanted to do something. And so she gave me a lot of suggestions about how to do things the right way. And of course, thanks to her, they were incorporated immediately, and it helped everybody feel safer. So, what I thought was going to be a really tragic experience, and obviously I don't want to minimize the impact on anybody that was affected, but just even their families of people who died, there was just this feeling of love and community and just a responsibility for others and a commitment for others that, did more for me than probably anything I learned in school. So I feel kind of selfish for that, and I didn't go there to save anybody's life, and I succeeded in not. But I felt like people helped me to. I wanted to go there to help heal people, and they healed me. So to that I would just say that we give comfort and we receive comfort often at the same time.
Wow, that was beautifully said. Please go on.
Well, I just wanted to say something about. I've been thinking about Florence Nightingale, and I'm not an expert on Florence Nightingale, but what I saw was nurses, if you will, running toward the flames, running toward danger when other people were running the other way, and even I had the impulse to run. And it was nurses that basically carried me. And when I think about, Florence Nightingale, she made a similar choice to run toward danger, to run toward the flames, if you will. And most of what she did, certainly in war, was to deal with infections. And she, was very much a scientist and a statistician, and she helped not, you know, she was a pioneer in medicine as well, and public health. And to that, and this, the comparisons to then and now, first of all, and many of you may know this, but in the United Kingdom, they just opened several emergency hospitals specifically for the treatment of COVID, and they're called Nightingale hospitals, you know, because of her work. And really, so I, without getting too carried away, what I'm trying to say is that for all of you on the call that are nurses, what I want you to know is that you're Florence. And, well, it's nice to know you. So I'll stop with that. Okay.
Wow. Well, I think that's beautifully said. And I think it is such a beautiful tribute to Florence Nightingale and to all the nurses out there, as you so aptly said, are kind of the embodiment of that spirit that they run into the flames as opposed to leaving. And at such a time as this with COVID, how incredibly heroic are these nurses on the front lines that day after day. And we heard a director of nursing from New Jersey talk about that last week. And I'm going to use that as a segue to take us to Dr. Barb Bowers, who's going to take Florence Nightingale a little bit more deeply, and she's going to share some insights around the work of Florence Nightingale, and then kind of take us to take a look at some of the greenhouse research, the research done on greenhouse, and how some of those things are applicable and relevant to what we're dealing with today.
Great, thank you, Susan. And I noticed from looking at the chat that there are lots of greenhouse nurses out there, some that I met during the study, so nice to see you again. And thank you, Dr. Evans, that was great. As a nurse, I appreciate your comments as well. And I think something that you didn't say, I want to expand this from nurses and physicians and other direct care workers, whether they're dietary or rehabilitation, and that's certainly a legacy from Florence Nightingale, is we need to all be organized and work together and recognize everybody's contribution. So thank you for that. I want to continue this celebration and this thank you to everybody out there by talking a little bit about Florence Nightingale. And as you've heard, it's the 200th birthday, the year of the nurse, the Nurses Week, so it's sort of all piled together. And it's fitting that this is we're talking about a time when there's a pandemic going on that's really on the shoulders of nurses. And I think long-term care nurses play a specific role. I'll talk a little bit later about the lack of visibility of nurses in long-term care, which we saw in this country and other countries. They kind of forgot to even count the death rate in long-term care. It was hospitalized people, and folks in, as they call them, care homes in England were not even counted or recognized. Same thing happened in New York. So we have some work to do in terms of gaining better visibility and recognition for what goes on in long-term care, the least resourced areas and probably the sickest people. So let me tell you a little bit about Florence Nightingale. She was amazing, as Dr. Evans has alluded to. Obviously, we see the reflection of her work today. She was born in 1820, so 200 years ago. She grew up in a really wealthy family, very high status family, very wealthy. She was highly educated. She had a number of courses in math. She spoke, I think, 5 languages fluently and other languages. So she was a really well-educated woman. This was a time when nice girls simply did not become nurses or caregivers. They didn't even call them nurses, and they were caretakers. The people who did that were people who were uneducated, sort of ill repute, had nothing else to do in life, and weren't very well thought of, and were not actually well informed about what they were doing. So it was something that was really looked down on socially. Florence Nightingale ignored these pretty strong social taboos and defied her parents' pleas for her not to do this. And she went off to Germany with determination and courage, went off to a place in Germany where they taught what they called religious volunteer caregivers. They were women who had a couple of weeks training and went into all kinds of places in the community, in hospitals all over, and just took care of people who needed to be cared for. It wasn't really a formal nursing program. This was in 1840. So I think I forgot to put up my PowerPoint, so there we go. All right, sorry about that. Okay. Hang on a second. There we go. All right. So we just had one slide anyway, so we're fine here. So this was a time when there was no understanding of the relationship between germs and infection. So it was interesting that she actually focused on that. At the time, infections were thought to be either spontaneous generation, they just happened, they came from nowhere, people just got infections and there was nothing that could ever be done to prevent them, or they were considered coming from what was called miasmas, which is bad night air. You've all seen curtains around beds that people used to have, and that was to keep out the dangerous night air. That was thought to be the source of a lot of diseases. So Louis Pasteur, who actually was the first to identify the relationship between germs and infection, wasn't until 1864. So that's a long time later. Remember, this is the 1940s when Florence Nightingale was doing her work. So Florence Nightingale, after she'd been to Germany and had her few weeks of training as a caregiver, was hearing about the high mortality rate of soldiers in the Crimean War. Crimean War was way over in the other side of the world in what's now the Ukraine. The British Army and allies were fighting the Russians. So she was hearing about all the death and the horrors that were happening over there, which simply inspired her to go. So she found 34 other women who were willing to go with her. I'm sure she was very convincing. And she trained them, and they boarded a ship and went off to the Crimea. When she got there, she described arriving in what she called a breeding ground for infectious disease. There was rampant cholera, typhoid, typhus, dysentery. It was a real mess. And she recognized, even though we didn't have germ theory at the time and people didn't know the relationship, she was convinced that a lot of this was because of the conditions in the area. What she described was an incredibly filthy environment. She said there was no ventilation. And bandages were initially applied and then never changed. So people had the first bandage that ever got put on was still there. Bedding, if there was any, was never changed. There was terrible overcrowding. The beds were actually touching each other. So if someone had an infection, it was certainly going to spread to the next person. There was sewage spilling out all over. There was lice and maggots crawling in the soldiers' wounds, rodents running around. So it was a real mess. So what did Florence do? She started calculating. She used her statistics and her math skills and started calculating the death rate and the causes of death. And what she discovered, which no one had known previously, was that 10 times the number of soldiers died from infection as died from war injuries. So it was really infection that was killing them. This actually hadn't been recognized before. And even though when she first arrived, the military there thought she was kind of a silly woman and was just going to get in the way, when she did this, she came up with these calculations, they actually started to listen to her and to gain some respect for her. So it was really, I have to say, the first time that there was any respect given to nursing as a profession and to a nurse. So that was a pretty important time. So she was well connected in the world. Her father was wealthy. She had a lot of wealthy friends and connections from when she grew up. So she wrote to the Queen and anybody else she'd ever met and said she needed bandages, she needed soap, she needed clean clothing for the soldiers. She wanted a crew of people who dealt with hygiene so they could clean out the sewers and stop the sewage from spilling over. She wanted people who could come and cut holes and create ventilation in the room so that people had fresh air, the soldiers had fresh air. And she wanted the space expanded so it would stop overcrowding. And what really got people to notice her work, and she even got a commendation from the Queen of England for this, was that there was a 2/3 reduction in the death rates after she got to work and started doing this. So it was pretty amazing. And obviously they didn't send her home as they had originally thought they were going to do. So a couple other things she did. She recognized that meaningful work is also important to healing. And so she set even the soldiers to work, people who were recovering and could do it. She got them up and they were scrubbing floors and scrubbing walls and scrubbing anything else they could find, so that they were engaged in meaningful work. And she got the place cleaned and kept cleaning it at the same time. She also got anybody who could read and write to help write letters home for the soldiers and to read letters that came in. She was one of the first to recognize that the relationship between families, important others in your life, and healing was pretty powerful. So she made sure that that was taken care of. And we certainly see these things reflected in nursing today. So it's not just infection, although she was certainly known for the impact that she had on infections, continued to have. It was really family relationships, social relationships, and meaningful engagement in work, and the relationship to health and healing, as well as overcrowding. That was actually started with Florence Nightingale. That sort of gets lost today. We have science to explain all these things now, but somehow she knew this before we had science. So she returned to England and she started the first formal nursing school at St. Thomas's Hospital in London, and that just happens to be the same hospital where Boris Johnson, the Prime Minister of England, was recently hospitalized with COVID-19. So interesting connection there. So let's fast forward now and look at the legacy of Florence Nightingale. As we talked about, it was the first time when there was real respectability for nursing, and I think that has continued. Nurses continually come up as the most respected profession in the country. That's been for several years running. She was one of the first to talk about the connection between family relationships and healing, between social engagement, meaningful activity, and health. She also looked at the importance of nutrition and healing. One of the other things that she did in the Crimea was the people out of the kitchen who were cooking at the time and set some of the women in to create not just more nutritious, but also more appealing meals, understanding the importance of that. She was one of the first to talk about the impact of space and crowding and the importance of working together. So she's left us with quite a profound legacy. I think everybody can see in all of these things how this has influenced the way we even talk about and engage in nursing today. So that takes us to the greenhouse model, which it looks like lots of you are familiar with, but probably not everybody. And I wanted to say, I love the greenhouse model. I think it's terrific. I think it's a wonderful embodiment of a lot of the things that we've just been talking about. And all these values as well as practices are alive and well in the greenhouse today. But I want to recognize that, of course, it's not just the greenhouse. These are fundamental nursing values. I think some of the practices that grow out of these values are, I will say, a little bit easier to implement in the greenhouse model because of the structure of the way things have been done, the change in the relationship between the direct care workers and the nurses, and certainly the architectural design. So it makes it a little bit easier. But I think there's a lot about the greenhouse model that can be adapted to other homes. And so I want to talk a little bit about that. So let's look at some of these things and how they operate. Things that are fundamental to the greenhouse model and to other places. Our research suggested, I want to preface it by saying that our research suggested that a lot of the things that the greenhouse model does, and to some extent in other places, but it really is reflected very strongly in the greenhouse model. These things actually improve the quality of life, as I think that's what the greenhouse model is the best known for, is it increases quality of life. But it also changes resident outcomes. There is an improvement in clinical outcomes. This was true of all of the greenhouses. They were in the upper range of quality for nursing homes, but also within the greenhouse homes, the ones that engaged in these practices, they all had the values, but the practices were stronger in some places than others, had a better outcome of care. And what we saw in particular, I'll just talk about two things in terms of better outcomes of care, is fewer hospital transfers. So less likely to get sick enough to go to the hospital and less likely to go. The other thing that I think is really important is that they were greenhouse residents were less likely to be transferred to hospitals at the end of life to care for them at the end of life when it was known that this was the end of life. A lot of times people panic and say get them to the hospital, even though we all know that's probably not the best response. But in the greenhouse homes, what we saw is the families were so comfortable with the staff, and the medical providers who oversaw the medical care were also more comfortable with the staff and knew that the staff knew the residents so well they would provide the care, and they or much more likely to be able to stay. So those are some of the most important things. And I think talk about consistent assignment as well. Consistent assignment in the greenhouse model is something that's a little bit different than it is in other places. One of the fundamentals in the greenhouse model is creating family-like relationships. They're small homes, so let's make ourselves like a family and have close relationships. The staff doesn't rotate, and the residents don't get moved around either. So, and forgive me for those of you who are in greenhouses and know this, but the staff doesn't get assigned there's 10 residents or 12 residents at home. You don't give one direct care worker this 6 and the other one the other 6. It's not my residents and your residents. We're all here together. We're like a family. We just pitch in. If the light goes on and I'm standing there, I go in. So, and there's no rotating. There's lower turnover than in other homes. And if somebody's sick, the staff figures out how to cover the staff that's usually there. They don't pull someone from an agency or from another building. It's always someone who's familiar. Those are really core values in the greenhouse, and they really pay off in the long run. So let's look a little bit at how this happens. So I think at least our research would suggest that one of the most important outcomes of this close relationship is the level of familiarity that the staff have of each of the residents. And we talked to a lot of medical providers who visited nursing homes and the greenhouses. And to a person, every one of them said, we always go to the direct care workers to ask them about a resident because they're the closest and they know, even though we also ask the nurses, but we always check in with the direct care workers. But the knowledge, the intimate knowledge and the level of knowledge that the direct care workers have about residents in the greenhouse home is so much greater than it is in any other place. They just know them so much better. They know every little thing about them. I'll give you a quick story. Somebody, a nurse was giving a older woman in greenhouse medication. The woman took the medication, took the water, swallowed it, everything looked fine. The direct care worker went up to the nurse and said, there's something wrong there. She's not right. Think she's getting sick. And the nurse said, why do you say that? And she said, well, you know, every other time when we're talking to her or she's out here, she stands up straight. She never leans on the wall. She's kind of leaning over a little bit like she's tired. And I saw her earlier and she looks just a little bit more tired than usual. And she was actually developing an infection, which they were able to get early. So this is really, really early identifying cues that suggest a possible change of condition. The other thing the greenhouse does is because the workers are in charge of multiple activities, you don't have rehab aides and dietary aides, the same people do all of that. So what that allows you to do is to see across people, to see across activities. So you might eat a little bit less at breakfast, not enough for anyone to notice that there's something wrong, just a little bit less. You might be a little bit slower or a little bit less engaged than usual in an activity. And by the time there's 2 or 3 of those things in a few hours, the alarm bells start to go off. So it's not the one thing you wouldn't have noticed. And so if you divide that among different people, you're never going to be able to put those pieces together and come up with an interpretation that maybe something's going on and intervene early. I think these are some of the most important things that allow the workers in greenhouse homes to identify change of condition early and largely responsible for the lower hospital transfer rate. The other thing that I think is really interesting, it's not a greenhouse requirement, certainly not specific to greenhouses, and more places are doing this, but I want to mention it because I think it's really important. And that is that I think Dr. Evans was talking about this, places that have a single small practice of physicians and nurse practitioners, primary care providers, who provide most of the residents in a home with medical oversight, seem to do much better. They also have a much greater level of familiarity with the resident. When you call someone on call, you're likely to get someone who knows them, who's seen them, so that, you know, almost everyone in a nursing home sounds like they could be in the hospital. They have such a collection of problems that it's often the default position to be safe and just send them. If you know them and you know, well, that's kind of their usual state, not too different, you're much more comfortable not sending them to a hospital. The other thing that having a continuous continuity with primary care providers is they get to know the staff and they know which staff can do what. And they're in a really good position to suggest where there might be some ongoing education that's needed in the staff and to help to do that. So those are some really important continuity of care issues that I think are actually vital and provide a lot of explanation for why this goes so well. There's also family style dining, and I don't have too much more time, but I want to just give you a couple stories about what happened at this family dining table, which we're all looking at here. So a few things that I've seen there. One, it's a much more social environment. I know it's not happening in all greenhouse homes anymore, but I think the habit, at least in the beginning and still in some places, of the staff, at least one person, sitting down and having a meal with the rest of the residents actually did some really wonderful things. For one thing, you get to observe people eating, and that tells you a lot about how they're doing, because appetite and swallowing and all kinds of things show up at the meal table, which you wouldn't otherwise see. It's a lot more engaging to be sitting with someone than just standing over their shoulder, helping them eat. It's a social time. The staff sitting at a table, even with people who have significant dementia, can keep the conversation going. Otherwise, it's quite difficult for people with dementia to engage in the conversation in a way that keeps it going. And staff are actually much better able to do that. And I've seen that happen a number of times where they actually they know so much about people, they can bring them into the conversation. And that works really well. The other thing that I saw that was really terrific was a woman who was having some difficulty swallowing. So instead of sending her off for an assessment, which she was terrified of doing, they invited the speech therapist to come and have dinner with them and to sit in a place where she could actually observe the person who was having trouble swallowing. She even gave the information about what sort of food she wanted served, textures and things so she could observe. A much less intrusive way to see how the person was doing and what the problems might be. This is part of what I think is wonderful about nurses who can think about very practical situations, problem solving in a context of good skill and knowledge and compassion all kind of rolled up in one. And of course the physical layout helps, but I don't think it's actually all that crucial. It's important, but not vital. So what about if you're not a greenhouse? And I know there are probably some people on here who are not in greenhouse homes. I think there are some important things to learn from what we've seen in greenhouse homes. The first is the consistent assignment. I did a study with a student where we actually collected the assignment sheets, the work assignment sheets from a lot of homes, over 100 homes that said they had consistent assignment in place. Many of these homes had up to 40 or 50 different direct care workers touching that person in a month's time. That's way too many. I mean, you're not going to get any familiarity with that. The staff aren't going to know who you are. You're not going to understand all the little things about them that make it important. The family isn't going to know who to talk to and who you are. I think we can do much better, no matter where we're working, in improving the continuity of care. Also, certainly lets you know early about change of condition. If you don't have that continuity, you are going to miss things. You don't know people well enough to know that something's changed. And so that happens, the identification of change of condition will happen much later. I think we can do a lot more to encourage consistent primary care providers. And the places I saw that did the best were where nurse practitioners spent 3, 4, sometimes 5 days, at least half a day in the facility. So they're there, they get to know everybody, they get to know the staff becomes very comfortable in talking to them. One of the things we heard from staff was, if they see something very subtle and they think, oh, I'm not really sure this is anything, they're very reluctant to actually bother a primary care provider to call up or send a fax, whatever they do. It sort of interrupts their work and they're thinking, oh, I better wait and see if it actually turns out to be anything. As it turns out, if the person is already in the building, you might just, and these nurses were much more comfortable going up to the primary care provider, who's generally a nurse practitioner, and saying, hey, as long as you're here, could you just take a look at her? It's probably nothing, but, and so that also involved, generated early identification of earlier change of condition. I think that also can build family trust in the home and in the providers, and that's something we can all do. I also think, I've heard all the caveats, all the challenges of this, but I think we can improve how meals are done, to not have people standing over older adults talking to each other, which happens in many nursing homes, to sit down and engage. Be interesting to have an experiment where you put a nurse or a direct care worker at each of the tables to talk with residents. I think it works brilliantly. It keeps them engaged. You get to see what they're eating. You encourage them to eat. So I think there's a whole lot more that we could do there. And the last thing I want to talk about really is something the greenhouse does really well, and that is to change the whole relationship between the nurse and the direct care worker, which actually turns into a better experience for them and better care for the older adults. So just a few things, not go in order here, but one of the things that many of the direct care workers said was how delightful it was that the greenhouse nurses didn't say to them at the end of each day, did you get your vital signs? Did you? And then the list of things that, as one direct care worker said to me, I've been getting vital signs on patients every day for 15 years. Why would I not do it today? I just resent being asked. So not being asked, the assumption is, of course, you've done your work. You're a responsible person and you've done your work. And that was something that was appreciated by most of the direct care workers. I think the other thing is when the relationships are closer and there's more collaboration, the nurses get to know what are those special skills that the direct care workers have. And I think one of the most important things is, I'll give you an example. It involves nurses being able to pitch in, willing to help out, to do things that are direct care worker work. So for example, if a nurse goes in, answers a light, the person wants to be taken to the toilet, instead of calling their CNA or their direct care worker, the nurse just takes them to the toilet. In the process, they get to see how the person is walking, how steady they are, how they get in and out of the bed. Are they able to get themselves into the toilet? What does their skin look like? What does the urine smell like? There's a whole lot of assessment that can get done at the same time. And then on top of that, if you see something like a red mark or something else, you can call in the direct care worker and explain why it's important to report something like that. And it's not just you should have reported it, but this is what it means. These are the things that we can do to help. And so if you see this again, please let me know. So that's sort of teaching in the moment, which is always more effective. And then all of this actually ends up with the direct care worker feeling more empowered and becoming a better team player. So when empowered can be, I'm an important part of this team and I have something important to contribute, as opposed to I'm doing it by myself. That's when things really were, it was just, the care was clearly much better and all of the workers were much happier. And so I'm going to end with that. Sorry if I've gone over a little bit with my time, but I wanted to just say congratulations. Let's take advantage of this time to show the world, make what you do more visible, raise your voices, let people know what's going on in there. It's actually a time when we have the world's attention, so let's make good use of that. And thank you.
Barb, that was beautiful. That was, I'm so appreciative. And I'm going to invite everybody to use the question and answer box there. And please, if you've got questions for Dr. Evans or for Dr. Bowers, please feel free to put them in the Q&A. I can't thank you enough. That was really fantastic. A nice presentation. We're getting lots of nice comments. Any questions for either Dr. Evans or for Dr. Bowers? I appreciate it, Barb, the way you you took us a little more deeply into the story of Florence Nightingale and really how incredible her time and our time right now really is. Can you please share that beautiful video? Yes, we will make sure that that will all be a part of what you will get. Probably within the next day, you'll get a copy of Barb's slides, you'll get the video and the link to this presentation. And how nice, nurses, was it that we could actually have Dr. Evans give us such a fitting tribute. All right, here is a question. What is the best way you train your direct care staff? Do you use face-to-face training or e-learning, or do you use champions? Any recommendations, Barb? And Barb, if you put your camera back on.
Oh, all right. I can do that.
And I don't know if there's any research that you've done that would kind of give us insight into what might be the best.
I'm sorry, I can't turn my video on. I don't know why, but we don't need it, so.
I hear your voice, that's good.
Yeah, okay.
Yeah, best way, is it e-learning, face-to-face, champions, anything from research that you might know?
Yeah, well, I think the one thing to say, and it's not so much research in long-term care, but it's on learning in general. And I think the wisdom is that the best way to learn is to do it in the moment, in the context. If you can't do it in the setting, like the sort of simple situation I described, to have people in a classroom, but to use experiences from their real life, things that they can resonate with, that they understand, and have people problem solve and think through applying information. Maybe I think what we tend to do is give people information and see if they can remember it, and that is so far short of being able to apply it. So I think this doesn't actually answer your question about the format, but I think I would just say don't ever just give people information, because there's like 5 to 10% of it that's ever going to be used, and those studies have been done in nursing homes. You need to give people information, help them work with it, help them problem solve about why they can apply it and why it doesn't, and then think about it that way. So, and I think in terms of the format, people are different, and now they sort of gravitate. Some people will only do in person, some like e-learning, some you give them questions and they go out and find their own things. I think we're at a time to ask people, what's the best, how do you like to learn? And they usually know.
That's insightful, and I appreciate the research lens that you brought to it. I will quote our Director of Education, Marla DeVries, who says, multimodality learning. So in other words, that it's not just one way, but actually, we're going to tap into different ways. And, the Greenhouse Project does use some face-to-face, and we certainly are doing much more right now at a time of social distancing with e-learning. And certainly there's something wonderful. I think you referred to it as mentors and teachers in the slide that you had, really talking about nurses and the role that they play to the application of knowledge or that learning in the moment that you described.
Right, and it makes the direct care workers feel really good about what they're doing, to be part of the team and part of the solution.
All right, let's see. Here's one. What do you think for Dr. Bowers? Here's for you, and then I've got one for Dr. Evans. What do you think is the most vital aspect of nurses in greenhouse homes that you think make it more optimal for infection control?
Well, it's interesting that infection control is a problem in every healthcare environment. There have been studies looking at whether physicians, nurses, anybody else washes their hands between patients, and there seems to be even a challenge there. I think one of the challenges for nurses in long-term care in particular is the lack of time. And so I think making sure, it's always, all the safety research tells us that when you make it the easiest to do the right thing, then it's going to happen. So where are the things to wash your hands? Everybody knows you're supposed to wash your hands, and it's not a knowledge question. So what would make it easier? And I think those are questions about, is it in the room? Is everything there? So, check it out and see, is everything here that makes it really easy, or is there a barrier to actually doing, whether it's changing the sheets and not contaminating them from one room to another. And I think the other thing is to engage everybody in the understanding of it's not about infection control. It's about the connection to the person that you're taking care of. It's about the impact on them. So I think to tell those stories in a way that's about what people really care about, what nurses really care about, which is the well-being of the patients, rather than we're going to get a citation or something else, which, you know, it's hard to get passionate about that.
Oh, I totally agree. So Dr. Evans, is there a way that nurses and physicians in greenhouse homes communicate or work differently than in traditional nursing homes?
Well, thank you for the question. I'm probably on mute here. Hang on.
No, you're good. You're good.
Okay. Okay. Gotcha.
Good.
Okay. And I very much enjoyed Dr. Bauer's comments as well. I haven't studied this specific issue, so I'm just giving you my opinion. As to quote Don Quixote, facts, dear Sancho, are the enemies of the truth. So I'll just tell you the truth, never mind the facts. It's my impression, and I think Dr. Bauer's work bears this out, that there's some difference in the population of people that work in greenhouse communities compared to others. And I'll say more about that tomorrow, but basically, you know, as I mentioned earlier, it's something that we're called to do, and I think there's a special attraction or appeal of greenhouses to certain people who really find that much closer to their own mission than perhaps others. And in addition, more traditional nursing homes have relied increasingly on post-acute care, post-hospital care, which is not, my impression is that's not nearly as prevalent in greenhouse homes, although I know there is some of that. And the reason I say that is because, and by the way, I know Joan Devine is on the call. She and I work very closely at Pioneer Network, and we spend a lot of time trying to make you know, the person the center of things and also make these environments more home-like. But just understand that when people have been trying to develop or post-acute care and rehab, they've oftentimes tried to make these places look more medical in order to appeal to people as some sort of place where they would recover from serious illness. And when you have IV poles and things like that, it undermines to some extent some of the home-like things that we're talking about. But I would say that in the same way that the nurses that work and the other caregivers that work at greenhouse communities are somewhat different, the same could be said for physicians and nurse practitioners. And as Dr. Bowers mentioned, there's probably less turnover of staff and a fewer number of people. And so communication is generally better because, well, I'll say it this way. There's more teamwork, and what I've tried to tell students of every stripe for the last 30 years is that you can't be part of a team if you're not present. And I tell that to doctors all the time too. You have to be present and you have to have something to offer. And just showing up for a meeting and listening or whatever, it doesn't count, unfortunately. Not for long anyway. I think that the philosophy of care is different. There's certainly some overlap. I don't want you to demean anybody that doesn't work in a greenhouse community. And I work in nursing homes that are not greenhouse communities, and I work there because a lot of the people that I love live there, and a lot of the people I love work there. So, but the care is best in any of these settings when you have a stable staff who feels committed, who feels a sense of agency, a feeling like that what they do matters and they have some control over what they're doing. And I think one of the things about the greenhouse model is in emphasizing understanding behavior and understanding that it's communication and not a disease. That helps caregivers at all levels, including CNAs, feel that they have more power and control over their situation, to feel like they can make a difference. And when you have people that share that philosophy, then all the communication is easier. It's not as emotionally charged. People aren't stressed out. They're not looking for magic pills, and you can communicate on a deeper level rather than just firefighting. Similarly, when you have a busy, post-acute care environment with shorter stay, there are a lot of hospital-based physicians who work there, and they don't, no offense to anybody that might be on the call, but they don't have the same training or focus. They think that the medicine learned in the hospital is what's appropriate everywhere. And most of what I do and my colleagues do is undo that care as much as we can. So, and the other thing is that, the best communication happens in an environment of trust. And so I think that's another area where greenhouses have really excelled at trying to create a community of trust for people that live there and for people that work there. I could go on, but I was not to get too carried away. I do want to, okay.
Thank you for that.
Sure.
Did you have one final comment while Janet's pulling up the slides? Janet, if you wouldn't mind pulling up the...
Well, I guess I would just say something. I was very impressed by Dr. Bauer's comments about education, and I want to say that empirically, well, first of all, I have used your work as a basis for things that I've done for a long time, and so I'm grateful for that. And you know, certainly in the long-term care world, there's a lot of computer-based learning and information. You know, and a lot of it's driven by surveys and regulations where, you know, somebody gets a deficiency and so they have to have an in-service, which is mostly informational. And I would just say that, first of all, having been a teacher for a long time, there's a big difference between teaching and learning, or as one of my mentors said, it's not what's taught, it's what's caught that matters. And if you're thinking about education and a particular method, I would just ask the question, you know, what's really the goal of education? What are you trying, what's the outcome that you want? And it's specifically, if what you're trying to do is teach people how to do something, in effect, either a skill or if you want ultimately to change behavior, then knowledge is often a prerequisite, but is generally very insufficient to achieve that outcome. And so that if you're thinking about changing behavior or task performance, that's an ongoing process. People have to practice. They have to do things in a safe environment. Dr. Bowers could talk about this way better than I could. I just wanted to underscore some of the things that she was saying. And you know, I just really want to be part of the family here. So I'll shut up and I'll sit at the table and do my.
You are okay. You are definitely part of the family. Okay. And in fact, you know, just to invite everybody who enjoyed your comments today, we'll have more of you tomorrow, and I'll talk more about that in just a minute. We're doing, to honor nurses, we are really doing a hashtag campaign. Hashtag 7 days of gratitude. We want to show our gratitude to nurses through this this week-long hashtag campaign. So we want you to post selfies along with your favorite nurse and put it on Facebook, on Instagram, on LinkedIn, wherever you can. But let's grab those nurses that have really made an impact in your life and hashtag 7 days of gratitude. Let's give a shout out to those nurses. Next slide will tell you about our Elevate series, the COVID webinar series that will happen tomorrow. And this is lessons learned from the Frontline. And we will have Dr. Evans back, who will share his experiences out from Washington State and Kirkland, Washington, where it first hit, to Dr. Jim Wright on the East Coast with the Canterbury facility in Richmond, Virginia. That's tomorrow at 2 o'clock. And the next slide. On May 11th, you will not want to miss this virtual toast to nurses. From 5 to 5:30, May 11, we are going to lift a glass and salute and toast our nurses out there. And if you're looking at the lovely young lady to the right, this is Perrin York. And for those of you who know Jack York, this is his daughter. And she is actually going to sing a toast to nurses. Steve McAlilly, our board chair, will be offering the toast 5 to 5:30, May 11th. That's Eastern time. And let's definitely plan to be there. Post your pictures and use that hashtag. And let's really give a shout out to nurses. And one more slide. We have a webinar to end our Nurses Week. We have another one, May 12th, and that would actually be Florence Nightingale's birthday, 200th birthday. You know, we've talked a lot. I talked to some nurses today, and they were really expressing the grief and the trauma, the loss that they're experiencing right now. So Kathleen Weisberg is going to do a presentation for us at 3 o'clock next Wednesday to really talk about how we can really support those that are experiencing such profound grief, loss, and trauma. So I thank everybody for coming. I would have you go to our website to find out more information on the Elevate series and other events that the Greenhouse Project will be hosting. To Dr. Evans and Dr. Bowers, my deepest gratitude to both of you. I appreciate your presentation today. For those of you who would like the nursing contact hours, or if you're an administrator and you want the NAP contact hour, you can send your email to M. Hoffner Thomas at the Greenhouse Project with the following information. And you can just take a look at that slide and get what you need. Nursing contact hours, same contact person, that's Mary M. Hoffner Thomas at the Greenhouse Project, and that's what you need. So thank you everyone for your time, for your attention, and again, a big debt of gratitude to our speakers and to our heroes, the nurses that are out there. Take care everyone and have a wonderful day.
Thank you.